One. Please start, sir. We are live.
Good evening and welcome everyone. I would like to invite to you all to Lung Cancer Treatment Update 2024. This is conducted by Dr. Kapil Goyal sir. He is a consultant medical oncologist from Rajiv Gandhi Cancer Institute, Delhi. This meeting is under the Cancer Research and Static Foundation. And I would like to hand over the mic to the sir. Sir, please welcome.
Good evening, everyone. Thank you for the warm welcome. So today we have gathered here to discuss various advances in the management of lung cancer under the symposium titled as Lung Cancer Treatment Update 2024. As we all know that the management of tobacco consumption in chewing tobacco format. So incidence of lung cancer has been rising, and it is also being seen that lung cancer is not limited to smokers anymore, and increasingly we are seeing lung cancer in female patients and patients who have never been a smoker. So till 2000 decades, so we were just dividing lung cancer based on the basis of morphology as small cell carcinoma and non-small cell carcinoma. With the advent of immunohistochemistry, we knew that even the NSCLC is diffuse carcinoma and adenocarcinoma, and we're treating them with chemotherapy only. Furthermore, as the biomolecular research progressed, we knew that there are multiple driver mutations associated with adenocarcinoma, and they are present in the non-smoker female population subgroup, and they are more common in Indian population. So prominent mutation, e.g., advent of tyrosine kinase inhibitors. So initial drugs were gefitinib and erlotinib. So these were the radical treatment in the area of precision oncology in the management of lung cancer. So from there, the survival improved and the patients were being managed without chemotherapy. Furthermore, as we grew in the research, so second generation TKI and third generation TKI have come. And now management of metastatic adenocarcinoma, particularly EGFR mutated subset, has undergone a radical change. And with all this new development happening, it is very, very important that we oncologists who are dealing with lung cancer patients on daily basis are very well versed in the recent developments so that we can give the best care available to our patients. So with this motive in mind, we have arranged this meeting, Lung Cancer Treatment Update 2024, where it's my pleasure to invite the esteemed oncologist in Delhi NCR. So this symposium will be constructed in 4 small talks. So one of them will be delivered by Dr. Aparna Dhar. Madam is a director of hereditary precision oncology and genetic counseling in Max Super Specialty Hospital, Saket. Ma'am will be taking a lecture on lung biopsy, principles of molecular and biomarker analysis, as we all know that it is very, very important right now. Next, we will have a talk by Dr. Rakesh Sharma, who is an associate consultant in Max Super Specialty Hospital, Saket, who will be talking about role of nutrition and protein supplement. Next, I will deliver a talk on osimertinib in EGFR mutated NSCLC patient, followed by final talk by Dr. Anshul Gupta, who is a consultant medical oncology, Max Hospital, Vaishali and Noida, who will be talking about treatment option for EGFR mutated metastatic NSCLC. So without further ado, I would like to invite Dr. Aparna Dhar, who is a director of hereditary precision oncology and genetic counseling at Max Hospital, Saket. Over to you, ma'am.
All right, good evening. Thank you, Dr. Kapil, for those very kind words. And so I've got quite the presentation, and I've got around 20-25 minutes, so I'm going to try and keep it short. And actually walk you through the journey of why molecular profiling is important. But more importantly, you've got the test, right? What do you do once you've got the biopsy sample? And I think first we need to know is that lung cancer, as Dr. Kapil very rightfully put, is molecularly very, very diverse. And if I look at the NSCLC cohort and just look at how we've evolved, we've gone from treating NSCLC as one large homogeneous group, and slowly, you've moved on to categorizing it based on its histological subtype, and then from there, and if I just look at the adenocarcinoma, which is obviously the most common, and you just go and look at its molecular profile, it is so diverse. And what's interesting is now, because with the advent of NGS and because we are starting to do a lot of molecular profiling, you are going to be seeing that a lot of times it's not just one oncogenic driver mutation. You're getting multiple oncogenic driver mutations in around 3% of your cases, as highlighted here. And even the NCCN is kind of getting on with the program and is recommending that we test upfront, in our NSCLC cases, not just an adenocarcinoma, but even if we look at a squamous cell carcinoma, so across the board, irrespective of histology, they are also advocating molecular profiling. And I think this is brilliant. And why is it so important? Because it's a no-brainer. There are enough studies that show that the overall survival of our patients are better in those who are molecularly matched versus those, is in fact double the OS versus those who were not molecularly matched. These TKIs work, and I know we're going to hear a lot of talks about the various TKIs, so I'm not going to spend too much time, but match therapy definitely leads to a better OS. And what once upon a time was just molecular profiling in advanced and metastatic disease, it's now even recommended in early, in those early stages, and where at least a minimum of your oncogenic drivers of ALK, EGFR, ROS1 is recommended, especially because you know that if they're there, these oncogenic drivers are contraindicated in the case of if you're going to go down the immunotherapy part. And the buck doesn't stop there. We've got some amazing studies where we're using ctDNA, which can also be used to detect minimal residual disease, MRD, after surgery in those resectable NSCLCs. And I think it was the TRACER-X study, if I'm not mistaken, where they took around 24 early stage NSCLC patients and they followed them longitudinally after resection. And what they saw was that I think around 93%, that was around 13 out of 14 of patients with disease who had a recurrence of disease actually were MRD positive on that ctDNA, and 90% of those, it's around 9 out of 10, who did not have a recurrence were MRD negative. So there are a lot of studies. Yes, we do know that when that MRD positive comes, we don't know what to do with it clinically because radiologically it's not still correlating, and this is able to pick it up even before radiology does. So while we're still trying to figure out how to place it, there's a lot of studies over here which assesses ctDNA for monitoring treatment responses and relapses, especially in those early stages. And there's some phenomenal work happening in that area. So what's your tissue journey like? So we know the different ways that you can take a biopsy sample. As much as I want to advocate and say, yeah, liquid biopsies are non-invasive, easy to do, you can really not forget the fact that tissue does obviously play a very, very important role, because you can't do any of your molecular profiling. I mean, you can do your molecular profiling, but it's always better understanding as to what is the histology. A, is it really malignant? B, what is the pathology? Is it adeno? Is it squamous, non-squamous? And that actually helps us understand, in conjunction with the patient's clinical and personal history, as to what treatment works best. So histological subtyping, absolutely important. Now, once you've done the typing and you know what your, you kind of have a diagnosis at present, what becomes important then is the next part when you do biomarker testing, right? Which is the main thing. This is why you're doing the molecular profiling, and this is essentially why I'm speaking too, is that you've got to take the tumor. You can use the tumor that's from the primary site or from metastatic sites, but you've got are suitable, they're good tissue samples. But what you've really got to be very careful about are those bone biopsies that can be very suboptimal due to the decalcification process, and which in turn during that process can lead to degradation of DNA. So you've got to be very careful. That's what leads to all those failures in your samples. And a couple of things that you can consider at this point, if you're looking at squamous cell NSCLC, you're looking at those mixed histologies, young individual, non-smoker, maybe a light smoker. These are all people that you need to consider for testing. What's also very important, it's not just about these processes, this journey from preliminary diagnosis to morphology, to extraction, to analysis. all this is not the only thing that's important. In this flow chart, it is the role of the key personnels in the wet lab, in that diagnosis up front. You need good surgeons, you need good interventional radiologists who can take those biopsy samples. Then it comes down to the pathologists who, where it comes to the diagnosis part of it, your lab, your lab staff, your lab personnel, your patients, obviously. And then once you do have a diagnosis, I think it becomes so important that when you're doing NGS or any molecular profiling, it's not just about the molecular scientists and your bioinformaticians. I think in today's day and age, it's becoming extremely important to have molecular oncogeneticists and genetic counselors on board, because clinical correlation, before just kind of copy pasting what the NGS system, punches out and says, oh, this mutation, this is what you should be treating with, is actually wrong. So you do need individuals in the back end who will actually help guide and walk you through as to what could, kind of make a more personalized report versus just printing stuff and handing it over to the oncologist. So very, very quickly, we know we've got the various sample types that are there for molecular profiling. I again say tissue is the gold standard. I'm not going to argue, but at diagnosis, you at diagnosis, you do a biopsy, you do a progression of biopsy, preferably from a new metastatic site, and the sample gets analyzed. But the ground reality is that as much as we'd like our blocks looking like this, due to processing issues, due to tissue being, due to logistics, due to just a host of maybe simple guidelines not being followed, simple processes not being followed, tissue does become an issue. And to combat this, this is where liquid biopsy is proving to be a very good alternative. So what you're doing is that you're essentially isolating the circulating tumor DNA, the ctDNA, from the bloodstream. Now, ctDNA is a somatic DNA. It's the it's a DNA that's released from the cancer cells into the bloodstream, and ctDNA is essentially isolated and molecular profiling is done. And now some of the key concerns that we've always had with respect to liquid biopsy has been its concordance with tissue biopsy. Now, we have studies like SLIP, NILE, PEN2, which are specifically for lung cancer, that have very beautifully illustrated that liquid biopsy isn't inferior to tissue biopsy. And it's also got a couple of pros if you think about it. You can use it for monitoring your treatment response, for detecting those resistance mutations up, quicker before you actually have a full-blown progression. And it helps tackle the issue of tumor heterogeneity. And obviously not forgetting the fact that it is non-invasive, so it's a little bit more easier on our patients. And keeping with this theme of liquid biopsies, in 2021, our ASALC consensus statement, which was led by Dr. Christian Rolfo, we were actually reminded that there were some very key differences between tissue and liquid biopsy, especially in lung cancer. Now, with tissue biopsy, of course, you get the cancer diagnosis and pathology information and assessment of markers like PD-L1 that are non-genomic. Now, you can argue and say that, yes, there are studies where we're using circulating tumor cells that could have a role in, helping detect these PD-L1s, but that's a talk for another day. But let's go back to tissue biopsy. Does take time to get the results, and it's also very challenging to repeat these biopsies, and it's not always reflective of the tumor heterogeneity. Liquid biopsy, on the other hand, is found to be highly concordant, fast, minimally invasive, and they are very easy to repeat and perhaps better to even capture the tumor heterogeneity. In addition, unfortunately, where the problem comes for us, and especially in our part of the world, because there's no standardization in labs and there's just so many labs mushrooming, sensitivity does become an issue with a lot of our domestic partners versus those maybe more robust liquid biopsies, panels like Guardant or Foundation or even Tempus. And we do struggle over here in our part of the world. And obviously everybody cannot afford those tests. And that's what kind of puts us on the back foot with liquid biopsies. So if you do not find something on a liquid biopsy, it's very important to do a reflex in the form of a tissue biopsy. So what was the ideal profiling strategy? So in continuation with the IASCLC 2021 consensus, the statement that they observed that was in treatment-naive patients, there were at least 3 approaches that were recommended. One was the very basic sequential approach. You did a tissue, it failed, and you went ahead and you did a liquid biopsy. The second was a complementary approach, which was essentially you did tissue liquid upfront together. The third was plasma first approach, which essentially was you're clear you're not going to get any, you're not going to have sufficient tissue. Rebiopsy was not an option or tumor was inaccessible. So at that point, you did plasma testing. Now we come to how do we test? We've got our samples sorted out. How do we test? Now we've got a variety. There are many technologies that are available to call out these variants. But for me, NGS is actually becoming my partner of choice. And I don't want to belittle any of the other standard of care platforms like RT-PCR and FISH and IHC, but I do feel with NGS where it really stands out is that we actually get the answer to the biology of the tumor in one sitting versus standard of care platforms. And in addition, I think where NGS is trumping and kind of proving to be more helpful, it is more cost effective. Improved TAT. Today we know those simple 10, 12, 20 gene lung panel reports, NGS comes in 15 days versus the whole process of reflex testing, which takes around 20, 25 days, and that also for just 3, 4 genes. You get tissue preservation over here. But the most important for me that really stands out, that makes me such a huge advocate for NGS is that one, you have the potential to discover actionable targets. Two, it also helps us identify those multiple oncogenic driver mutations that could be present in our patient's tumor. And with next generation sequencing, you get to call them out. In addition, you also get those resistance mutations. So you're kind of getting the whole picture, which kind of helps you and chart out a more personalized treatment approach for your patients. And this is data from my cancer genetics clinic, where around 660 patients were there, out of which around 40% we had, we found actionable biomarkers. But for me, what really helped were all these concomitant mutations that we were seeing that helped me work with our, treating medical oncologists to actually plan out a more personalized treatment, which in turn obviously helped, it was a good guide for us and we saw a much more better response. And to further prove my point, I'm actually going to seek the help of two biomarkers that I think we're all very comfortable with in our clinical practice, EGFR and ALK. So in an unselected population, from there you identify, let's say, EGFR, and you start your patient on a TKI, and then after a period of time, a patient develops a resistance, and we use imaging to confirm it. We do a rebiopsy from the new metastatic site. Ideally, not an option, we do a liquid biopsy. Irrespective of sample type, we send the sample for molecular profiling. And we've identified the most common mutation that we do know in EGFR, which is the T790M. Now, this we know accounts for around 60% of the cases, but that's if you would have done a very basic EGFR panel. But when you do NGS, which is now preferred because we know that it's not just limited to T790M. There are a host of other resistance mutations. You've got your MET amplifications, you've got your PIK3CA, your HER2, and more importantly enough, you could have the small cell transformations, and all of this can be identified using NGS as your platform of choice. And similarly, when your patient progresses on osimertinib, it acquires resistance mutations. And then again, we saw this, I think, in the or 3 trials, we saw that around 15% of these patients, they actually get a C797X mutation. And then there is about 19% that are positive for a MET exon amplification. There's HER2 amplification in around 5%. And all these mutations can be reported in one go using NGS as your platform of choice. And similarly with ALK, it's on, ALK resistance mutations, on progression, the type of ALK mutation, the fusion partner, the point mutations, these become very important in guiding therapy. Like, for example, we know G1202R is a known resistance mutation to crizotinib. So all of this actually helps us identifying and increasing matching patients to targeted therapies, which we know improves the OS of our patients. And there is a plethora of biomarkers that are there that are associated with therapies. And as you can see, we've got our EGFR, which now I like calling it the new kid in the block, because the more we test, the more we do NGS, the more we understand these so-called genes that we thought we knew it all. And then you've got your NTRAX, RETs, METs, exon 20 insertions, KRAS 12C. So I'm just very quickly going to walk you through them. So I want to focus some time on these EGFR mutations. Again, because these are different mutations that can get missed out on RT-PCR or those hotspot tests, that's why NGS becomes your preferred platform. And as we know EGFR now, we better understand it that they're grouped into three major categories. First, the very classical sensitizing mutations, as we all know them to be, like the exon 19 deletion and L858R. You've got exon 19 deletions and L858R. Then two, you've got the atypical uncommon mutations like your G719X, your L861Q, you've got your S768I, and then you've got this third one is those exon 20 mutations. So if we take a quick look at these very uncommon mutations, which actually aren't very uncommon, especially now with the increase in CGP testing, your G719X is seen in exon 18, where you can actually target them with neratinib and afatinib. It's sensitive to these particular, it's sensitive to first generation TKIs. Similarly, the S768I and the L8Q1, the L861Q, sorry, these are all tongue twisters. These are all very sensitive to your first generation point mutation. And in the case of a lot of these compound EGFR mutations, they're actually seen together. And when the 719X is seen with the L861Q, or the G719X is seen with the S768I, these have a higher sensitivity to RTKIs. And it's extremely important that when we are targeting these, and when you see an EGFR, it's not just, oh, let's just give it osimertinib, let's just give it this, let's just give it that. You have to be very careful as to which exon it is. Exon 18 actually codes for, let me just go. Okay, here you go. So your exon 18 mutations are essentially there from codons. Let me see, where did the slide go? Okay, are actually coding from our codon 688 to 728, right? And this is around, and your G719X accounts for around 2 to 4%. Now, why is this? Why do we prefer our first generation here? Is that because these mutations has alanine, serine, or cysteine, or aspartic acid in the position of the glycine residue. So what happens? It becomes it makes it responsive to the EGFR TKI, the afatinib, but because it's in the P-ship loop, this is what hinders the binding of osimertinib. That's why it's not the ideal drug. And that's why it becomes really important going back and looking as to where are these mutations. Similarly, when we look at those exon 20 insertion mutations, it becomes really important to know exactly which, exactly which codon is it, because different codons actually respond differently. And what actually makes exon 20 insertion so special is that it comes to the TKI domain, right? So the entire region is what we call of the C helix and the loop that follows the C helix. So if you see over here that exons that are coding for all these amino acids from 761, 2, 3, right up, and so on and so forth. And due to advancements in technology, which is our NGS in particular, we have specific alterations that show specific response to certain treatments. So from 763 to 764, if it's inserted or it's altered, these will always show sensitivity to first generation. Similarly, 766 to 770, they do have a response to poziotinib, and similarly 773 to 774 is afatinib. Thus, it's not just about reporting exon 20 insertion positive. The region of exon 20 is extremely, extremely important. If undetected, the consequences is that if undetected or untreated, patients are at a high risk of rapid disease progression. And the reason is that, and why do these exon 20 insertions, why have they become a different class of their own? Is because they actually function very differently as compared to the other common EGFR mutations, and this is due to the fact that they reduce the size of the drug binding pocket and have an affinity that has an affinity for most of the TKIs that are indicated for common EGFR mutations. Now, okay, let's just go here. Now, if we look at the NTRK mutations, right? So NTRK is essentially fusions. They're very rare. They constitute for around 0.3% of all NSCLC cases, and these are agnostic markers. And as we know from these waterfall plots, that for entrectinib and larotrectinib, it illustrates that majority of these solid, it actually illustrates, I'm so sorry, it illustrates that majority of solid tumors, lung included, do respond very well to these TKIs. And so what are we looking for? You're essentially looking for the rearrangement of the NTRK gene that couples with the tyrosine kinase domain with a 5' fusion partner to generate a chimeric TRK protein ligand binding domain, in short, a fusion. Now, when we're looking, and some of the most common fusions that we do see in lung are NTRK1 teams up with the fusion partner is TPM3, NTRK3 is with ETV6, and this is what we normally see in our NSCLC cases. Now, you're looking for a fusion. This flowchart, of the testing method is what's recommended by ESMO, but in my very, very humble opinion, NTRK are translocations, be it 1, 2, or 3. NTRK3 actually has a low sensitivity on IHC, whereas NTRK1 has a low specificity and sensitivity to FISH. So the preferred platform for any fusion, and this should be a ground rule, fusion, be it NTRK, be it RET, MET, ALK, ROS1, whatever you're looking for, a fusion should always be RNA NGS, as it has a higher sensitivity and specificity for calling out these mutations. And this is also being echoed not only for NTRK, but for all these fusions, that it should be RNA NGS. Similarly, RET. Now, RET is synonymous with papillary thyroid carcinoma, but interestingly, it constitutes for around 1 to 2% of NSCLC cases. The RET gene arrangement actually gives rise to something of a chimeric cytosolic protein, which constitutively activates the RET kinase domain. KIF5B is the most common fusion partner that we see in our NSCLC cases. And again, the preferred one is RNA NGS. Therapy options is selpercatinib that you get from the Libretto 001 trials, and pralsetinib that we get from the ARROW trials. We go on to MET exon 14 skipping, which is essentially a mutation at the junction of exon 13 and exon 14. So the product that you're looking for is a fusion of exon 13 and exon 15, which gets formed. It's again a fusion, so RNA NGS. Therapy options are crizotinib from the Profile 1 trial. You got tepotinib from the Vision trials and capmatinib from the Geometry trials. Now we move on to KRAS. KRAS mutations, we know, are the most common mutations in NSCLC. They constitute for around 25 to 33%, and especially in our smoking cohort. Now, what happens here is the GTP binding protein, it connects to the receptor of the TKA. Now, the RAS sends activating signals to a number of cellular pathways that are involved in cell proliferation and survival. And these are mutually exclusive with EGFR and ALK mutations. So from the KRAS subtype G12C, which is the most common, it constitutes for around 40% of our KRAS cases. It actually is indicative of poor prognosis, obviously, versus a wild-type KRAS. And what's very interesting in this subgroup are the varying TMB rates. So G13 has a high one, followed by G12C, and G12D has a propensity for a much more lower TMB. Even the PDL1 rates, kind of differ. The TPS scores differ. G12C is known to being higher versus G12D. So Torosib is your target that is available, the therapy that is available. These are point mutations, so DNA NGS can be your preferred treatment, your preferred platform of choice. We very quickly wind up by just saying that, from the Keynote 010 trials, Checkmate 017, Oak trials, from all of these, we have demonstrated the utility of PD-L1, and that's why it's a biomarker that's recommended upfront. 3 clones, we've got the 22C3, we've got the SP263, and the SP142, various cutoff scores. Based on that, we see if a patient is a candidate for immunotherapy. Similarly, you've got other biomarkers like tumor mutation burden. It's slightly controversial with respect to immunotherapy in lung cancer. But the key theory over here is that every cancer has a mutation, more the mutation, higher the neoantigen, and possibly a better immune response. So in a lab on a minimum of around 250 gene panel, you look at the number of genetic aberrations in the exonic region. This gives an indirect idea whether or not the tumor you're dealing with has a high neoantigen load or a low neoantigen load. However, here's where I think there is an issue with this theory. One, not every mutation will cause a tumor to have a neoantigen load. And even if they have antigens, it may not necessarily be a neoantigen that is recognized by the immune system. So the neoantigen may really not induce the immune response that we're looking for. And you've got different studies that have, different high cutoffs. So what score really works? And how do we know if that score is the right cutoff in which the neoantigen will cause an immune response? I think more studies are required. It is experimental. However, FDA has given blanket approvals based on the Keynote 158 trials. So tread carefully. If you've got your back up against the wall, you don't have any other option. TMB is recognized, but do go back and see that data with a microscope. There were no lung cancer patients. So there was one lung cancer patient in that entire cohort. And I think this particular chart best summarizes my talk. Around 50% of your patients will have some sort of an actionable biomarker, and this is why testing NGS has become so important. But the key takeaway message here is that your NGS, the validation, the laboratory, the type of NGS, what is being tested. If your NGS report comes positive in those young, non-smoker females, patients of yours, go back and check, was DNA and RNA done? Look at validation studies. It's highly possible something could have been missed out. And on that note, I'm going to end my talk here. Thank you so much for listening. And I apologize for the waffling today. I'm not feeling very well, but thank you.
Thank you very much, ma'am, for the wonderful presentation. So it was a very enlightening presentation, and I'm sure all of us got to learn a lot from this presentation. So thank you so much. If there are any questions, so if there are no questions, so I think I may invite my next speaker, Dr. Rakesh Sharma. Dr. Rakesh Sharma is an associate consultant in Max Super Specialty Hospital, Saket. He will be talking about role of nutrition and protein supplement. Over to you, Dr. Rakesh.
Thank you, Dr. Kapil. Tech support, please share my slides.
Support team, Tarunji, please play the slide.
Yeah, wait, sir.
Otherwise, I am playing, no issue.
He will play, sir. Just a second.
Thank you. So move on to next slide. Topic given to me is role of nutrition and protein supplements in cancer patient. It's a really difficult and controversial topic. So I'll try to make it as simple as possible. Next slide, please. So malnutrition and muscle loss is a frequent problem in cancer patients, and they can have this issue at the diagnosis only, or they will subsequently develop it during the due course of the disease. And it may be due to multiple reasons, including inadequate food intake, decreased physical activity, and in general a catabolic state of cancer. Next. So therefore, a standard operating procedure, responsibility, and quality control process should be established at each institution which is treating cancer to screen, prevent, assess in detail, monitor, and treat malnutrition. Next slide. So in total, as per the Global, this is relatively older data. As per Global data, around 20 million new cancer cases were diagnosed worldwide in 2020, and approximately half of the deaths, around 10 million deaths, that were attributed to cancer. So similarly, in India, around 1.14 million cases of cancers were diagnosed, and approximately 5 lakh cancer deaths were reported. Next, please. So the burden is huge. So the prevalence of cancer, next slide, please. So the prevalence of cancer cachexia mm, parallels the incidence of or the burden of cancer. Next slide. So patients with cancer have altered nutritional status, as I highlighted at presentation, or it can develop during the course of disease itself. So approximately 30 to 85% of patients with cancer reported with malnutrition. Next slide. So prevalence of malnutrition, as we can see that in oncology patient, it is around 70%, which is the highest prevalence of malnutrition as compared to the other illnesses pertaining to different organ system diseases. Next slide. So at first medical oncology visit, overt malnutrition, it varies from the site of the disease. So in GI cancers, GI, pancreatic, head and neck cancer, or the cancers that hamper the intake of nutrients, the prevalence is higher. So in gastroesophageal, pancreas, the prevalence of malnutrition at onset is in itself is around 25%. So uh, this can be a pretty challenging issue in these cases, and this hampers the administration of treatment planning, and ultimately deciding intent of treatment. Next slide. So, what are the metabolic changes in oncology patients that lead to the development of malnutrition and ultimately cancer cachexia? So first is the brain. In general, in patients with cancer, the food intake is less as compared to the normal population. And cancer is a pro-inflammatory state. It releases cytokines like TNF alpha, IL-1, IL-6. So these cytokines lead to muscles lead to insulin resistance, decreased synthesis, increased breakdown of muscle, in skeletal muscle and fat mass wasting. In liver, increased nitrogen loss, and in fat, increased lipolysis. So all these factors contribute to the loss of fat, muscle, nitrogen, decrease intake. All these factors lead to ultimate development of cancer cachexia. Next slide. So these are the independent factors that are associated with malnutrition. So, and in general, the patient may be underweight, or there may be a presentation of more than 5% weight loss, site of the malignancy, chemotherapy, chemoradiotherapy. This is the type of the treatment that will ultimately determine how patient will develop cachexia, or whether he or she will develop cachexia or not. Next slide. So there are many causes, many steps at which malnutrition can develop. So these can be divided into 3 steps: before entering hospital, in hospital, and after hospital. So before hospital, these are related to the patient itself, like poverty, local availability, meals, and food fads, loneliness, depression, old age, tobacco uses, and others. In hospital, it can be not screened, anxiety, investigation, starvation, food choices, GI problem, fever, sepsis, surgery. So multiple problems that can hamper the administration of nutrition in hospital. After discharge, no advice, food fads, no supervision, loneliness, medication. So multiple factors are there that can ultimately lead to the development of malnutrition and cachexia. Next. So it malnutrition significantly increases post-op morbidity, mortality, and cost. Next slide. So how malnutrition or cachexias are related? So there are 3 stages: pre-cachexia, cachexia, and refractory cachexia, and ultimately death. So up to 20% of the cancer-related death can be attributed to cancer cachexia. Next. So this is another way of saying 1 in 5 patients with cancer dies from cachexia, not from cancer itself. Next slide. So nutritional problem can develop into the during the course of the treatment also. So in patients receiving radiotherapy and chemotherapy can have certain issues that can ultimately lead to malnutrition and cachexia. Most important, one of them is nausea and vomiting, altered taste sensation, food aversion, mucositis, weight loss. So these are the multiple factors that determine the reduced intake of food, nutrition, and ultimately development of malnutrition in patients undergoing radiotherapy and chemotherapy. Next slide. So muscle depletion is associated with increased risk of dose limiting toxicity. So there is a common we use to check albumin level during before starting any chemotherapy that determines the overall nutritional status of the patient. If the nutritional status is not that good, then the ability to tolerate the chemotherapy or cancer directed therapy is less as compared to a person with well built good performance status. So there is a higher chances of development of dose limiting toxicity, as this graph is clearly highlighting. If patient is normal and as compared to if patient is sarcopenic, the tendency to develop dose limiting toxicity increases exponentially. It can go up to 80%. So chemotherapy is reduced for more than 20% or terminated in sarcopenic patient due to excess toxicity, and it is ultimately a cause of stopping the cancer related treatment. Next slide. Next. So other factors that are related to malnutrition and cachexia in cancer patients that are non-nutritional. So it can be severe immune suppression. Mucous lining is disrupted because of the mucositis. Gut motility is altered. Treatment lasts for several months. In some cases, treatment can be more than 6 months. In acute leukemia, in certain leukemias, it can be up to 3 years. So increased treatment and associated costs. So these are the other factors that are non-nutritional but can lead to the development of malnutrition. Next slide. So there is a dynamic relationship between nutritional depletion and cancer treatment. So as the duration of cancer treatment increases, tendency to develop malnutrition decreases. As we have seen in our own practices, patient during the course of the treatment, they tend to lose weight, they tend to lose muscle mass, malnutrition, their general reports parameter tend to decline in during the course of the treatment. Next slide. Next. So treatment of supportive care is one of the integral part of the cancer treatment. So for like nausea, vomiting, everyone is using prophylactic treatment to prevent development of nausea, vomiting. So other integral parts should be oral nutritional supplements. If patient is not able to take orally, then parenteral and enteral nutrition should be considered. So it is an integral component of supportive care. Next slide. So nutritional therapy can be oral, enteral. Enteral can be through in this nasojejunal, nasogastric, or PEG directed, parenteral nutrition, and immunonutrition. We will be discussing about first three categories. Next slide. So oral nutritional supports. The goal is to increase the absorptive capacity of digestive tract, minimize GI symptoms, which reduce oral intake. Next slide. So, a role of protein. As we know, cancer in itself is a catabolic state, so the requirement of protein is higher as compared to the normal population because of the hypermetabolism. Next slide. So, protein supplement should be considered in every patient. It can be considered through whey protein powders, which are available. It can be used either with water, milk, can be used in the form of shakes. It is easily available, can be taken even without compromising the overall intake. So small quantity of protein shake can fulfill the need of the patient for a day of the protein requirement. So it should be a routine practices, although it is a controversial topic, as natural protein should be considered. Most of the old medical oncologists prefer to use the natural protein sources, but nowadays there is a common trend of prescribing protein powder to each and every cancer patient. So how does this act? It increase the production of natural glutathione, which protects cancer cell and eliminate cancer causing, which protect the body from cancer cells and ultimately eliminate these cells. So these protein powders can help in building the nutrition of the patient, can prevent side effects from the chemotherapy, and in general can prevent further damage caused by the cancer cells. Next slide. So protein is needed for body maintenance, growth, and repair. So this everyone knows about this formation and maintenance of muscle mass, connective tissue, red blood cells. So each and every process of the body requires protein in any form, like enzymes. Muscles require protein. So I think there can be another lecture on this. So I'll skip this part and move on to next topic. Next slide, sorry. So sources of protein, there are ample sources like plant and animal-based protein. Animal-based protein, we can have eggs, chicken, beef, lamb, pork. There are multiple sources that can be animal sources, and others are plant-based sources like nuts, lentils, tofu, legumes, grains. So next slide, please. Enteral nutrition. So this is the infusion of feeding solution through tubes into the digesting tract. So this is to bypass the obstruction, like in head and neck cancer, we can insert nasojejunal tube, nasogastric tube, or PEG. So it provides continuous infusion of nutrition, can be safely used, provide access for nutritions which are not palatable. Next slide. So recommended calorie and protein intake in cancer patients. So in general, the calorie requirement is around 25 to 35 kilocalorie per kg per day, out of which glucose should be less than 5 gram per kg per day. Lipids should be around 5.5 to 1 gram per kg per day, and protein should be around 1.5 to 2 gram per kg per day. So which is almost double of what a normal individual requires in terms of protein requirement. Next slide, please. So enteral or parenteral nutrition, both have their own advantages and disadvantages, and this two methods should be complementary, not competitive. Next slide. Home nutrition support. So can it be considered? Yes, in terminally ill patient it can be considered after a discussion with their treating physician. It has shown to have proven efficacy and can be administered under the guidance of treating physicians safely. Next slide. So nutrition therapy in oncology patient. So correction of malnutrition, prevention of muscle mass and muscle loss and muscle function, modulation of pharmacologic or physiologic effect of chemotherapy. So these are in general what is the goal of the nutrition in oncology patient during their treatment. Next slide. Goals of oncology specific nutrition is to maintain the body weight, prevent or improve muscle mass and function, reduce inflammation, improve immunity, improve tolerance to multimodal cancer therapy. Next slide. So high protein, high energy, and high lipid intake. Consider omega-3 fatty acid also. So with these measures, we can meet these 5 goals during cancer treatment. Next slide. So overall, oral nutritional intervention has been shown to improve the quality of life in patients, particularly in malnourished or patients who are at the risk of development of nutritional deficiency. And ultimately, it has been shown to improve overall survival and reduce mortality in cancer patients. Next slide. So this is a study in which early nutritional intervention in patients with head and neck cancer was considered. So there were two groups in which PEG was inserted before starting CRT, and in second group, PEG was inserted as per the need of the patient. So it has been shown in this study those patients in which preemptively before starting CRT, PEG was inserted. So there were less RT delays, reduced toxicity, reduced requirement of admissions because of mucositis, and higher chances of completion of planned treatment. So we can see with this study that early nutritional intervention can help completing treatment, reduces toxicity, reduces hospital stay, and in later run can ultimately improve overall survival. Next slide. So this is the ultimate result of this study in which early PEG was shown to improve overall survival also and reduced interruption of treatment, higher chances of completion of planned treatment. Next slide. So next, next. Next, so the in this similarly in NSCLC, this was also study that patients really receiving oral nutritional support in metastatic NSCLC patient. It improves energy, protein intake, body composition, and decreased fatigue, loss of appetite, and reduced neuropathy, which is a common side effect of cancer therapy in NSCLC, which is paclitaxel, which is commonly used in NSCLC chemotherapy regimens. Next slide. So what is the role of micronutrients in oncological intervention? Although it is a controversial topic, some says that these nutrition micronutrients can prevent development of cancer. However, certain studies have found that supplementing with these in preventive studies using these nutrition can lead to higher chances of development of cancers. Although these micronutrients needs to be supplemented in cancer patients, particularly there is a mention of selenium, and it should be tailored as per the individual's background, diet, genetics, tumor histology, and treatment, and may yield some benefit in certain patients. Next slide. Next. So this is in short around daily calorie requirements in cancer patient is around 25 to 35 kilocalorie per kg per day. Protein requirement is around 1.5 to 2 gram. Lipid requirement is around 0.5 to 1 gram per kg per day. Next slide. So all the micronutrients should be supplemented like omega-3 fatty acid, glutamine, arginine, and trace. These nutrients are shown to improve lean body mass, reduce infectious complication. It helps in wound healing, prevent or ameliorate treatment-related side effects like diarrhea and mucositis, restore organ function, improve overall clinical outcomes. Next slide. So, as per the ESPN guidelines, all patients should be screened for malnutrition irrespective of BMI and weight. Increase nutrition assessment to include measures of anorexia, body composition, inflammatory biomarkers, resting energy, expenditure, physical function. Use nutritional intervention with individualized plan, including care focused on increasing nutritional intake, decreasing inflammation, hypermetabolic stress, and increase physical activity. Next slide. So take home message, malnutrition is a very common problem in cancer patients. They are very high risk of developing malnutrition. If they don't present it at onset, they can develop ultimately during the course of the disease. It ultimately leads to prolonged hospital stay, poor quality of life, hamper overall survival also. So nutritional support should start at the onset of the treatment only rather than planning it later during the course of treatment. And it should nutrition strategies should modulate or reduce cachexia, improve quality of life, oncology treatment tolerance, and survival in cancer patient. So with this, I will conclude my discussion. I will be happy to answer any questions if there are any.
Thanks a lot, Dr. Rakesh. This was a very enriching discussion. As we all know, that nutrition is often an overlooked aspect in the cancer care in patients of cancer. So I just wanted to ask, how do you particularly decide whether a patient is eligible for some kind of protein supplementation?
But if you ask me, I am not generally prescribing any protein powder to all my patients. Usually, I tend to look at the albumin status of the patient, and if it is around 3, generally we ask them to eat high protein diet rather than prescribing any protein powder. If patient asks that I can use, then obviously we tend to say yes, you can use. There is no denying that you can, there are no guidelines that it should be used. But if patient wishes to use, you can say always say yes, yes, you can use that. But there are no guidelines that supports that protein powder should be prescribed to all cancer patients as per the sarcopenia level. I don't find any guidelines, but yes, you can always over treat the patient rather than under treating.
Agreed, agreed. So the most important point that we have to see here is that the nutritional assessment at the outset is very important. If we feel that the oral intake is not adequate or patient is consistently losing weight, then the early intervention is required rather than waiting for the frank cancer cachexia to develop. So thanks a lot, Dr. Rakesh. Thank you for sparing your valuable time. So next, I will be taking the next talk about role of management of early EGFR mutated lung cancer. Organizers, please allow me to. Yeah. So I hope my slides are visible and I'm audible to everyone.
Yes, sir. Can you make it full? It is full screen now. Perfect.
It's full now.
Yes, sir.
Okay. Hello everyone. So the topic that I will talking about is osimertinib in early EGFR mutated NSCLC patient, mainly talking about the ADAURA trial. As we all know that 1 in 3 patients with NSCLC present with resectable disease. It's a leading cause of cancer death, which accounts for more than 17 lakhs deaths annually, and as many deaths as breast, prostate, and colorectal cancer combined. So, although speaking the incidence wise, the lung cancer may be behind breast cancer and cervical cancer, but if we look into the mortality, it is the leading cause of cancer death. NSCLC represents 85% of all lung cancer cases, with the remaining 30%, 15% of the patient being small cell lung cancer, and estimated 30% of the patient present with resectable disease at diagnosis. So, what is a localized or early stage disease? It is lung cancer up to stage 1B, while regionally or locally advanced stage is called as stage 2 and stage 3A diseases. So outcomes in early stage NSCLC need to be improved, as we know that surgery is the primary treatment for patients with early stage NSCLC. Adjuvant cisplatin-based chemotherapy is recommended for patients with resected stage 2 to 3A NSCLC and select patients with stage 1B disease. Results from large randomized trials and meta-analysis showed a 5-year OS benefit with adjuvant chemotherapy in patients with early stage NSCLC, with the overall survival benefit of hazard ratio 0.89. DFS also favored adjuvant chemotherapy. DFS hazard ratio was 0.84. Overall, disease recurrence or death following surgery and adjuvant chemotherapy remains high across disease stages, whether it is localized or regionally or locally advanced disease, and there is an unmet need to improve survival outcome. It is estimated that in stage 1B patient, 5-year recurrence rate is 45%, and understandably, it increases with the stage 3 and 2 and 3. In stage 2, 62% relapse within 5 years, while this number goes up to 76% in stage 3. Based on a limited number of studies, the prevalence of EGFR mutations appear broadly similar across disease stages. And we look through stage 1, 2, 3, 4 in Asian population, the incidence of EGFR mutation is particularly high, ranging from approximately 1/3 to 50% of the patient, while it is lower in the Caucasian, US, and European population. Overall estimated prevalence is 30 to 40% in Asian population, while it is only 10 to 20% in Caucasian population. If EGFR TKIs were available in the resectable setting, a similar portion of patients may be able to benefit compared to advanced settings. Keeping these points in mind, the ADAURA trial was designed, which is evaluation of osimertinib as adjuvant therapy in patients with stage 1B to 3A EGFR mutation positive NSCLC after complete tumor resection. So it was a phase 3 double-blind study design in which the key inclusion criteria were age more than 18 years, WHO performance status 0 and 1, confirmed primary non-squamous NSCLC with exon 19 deletion or L858R EGFR mutation. Brain imaging has to be done if it was not completed pre-operatively. Complete resection with negative margin. Maximum interval between surgery and randomization has to be 10 weeks without adjuvant chemotherapy, and up to 26 weeks were allowed if adjuvant chemotherapy was used. These patients were stratified according to the stage, the EGFR mutation and race, in two arms in 1:1 ratio. The experimental arm was osimertinib 80 mg once a day, while placebo arm was also given placebo tablet once a day. Total number of patients was 682. Planned treatment duration was 3 years, and treatment had to continue until disease recurrence or treatment completion or discontinuation criteria were met. The follow-up was done until recurrence at week 12 and week 24, and then every 24 weeks to 5 years, and then yearly. After recurrence, every 24 weeks for 5 years, and then yearly. The primary endpoints were DFS by investigator assessment in stage 2 to 3A patient designed for superiority under the assumed DFS hazard ratio of 0.7. Secondary endpoint was DFS in the overall population, DFS at 2, 3, 4, and 5-year landmark, overall survival, safety, and health-related quality of life. Following IDMC recommendation, the study was unblinded early due to efficacy, and we are reporting an unplanned interim analysis. At the time of unblinding of the study had completed enrollment, and all patients were followed up for a minimum of 1 year. So inclusion criteria is already mentioned were adult more than 18 years, primary non-squamous NSCLC, post-operatively staged as stage 1B to 3A, central confirmation of EGFR mutation of either exon 19 deletion or L858R mutation, the standard post-operative adjuvant chemotherapy consisting of a platinum doublet for 4 cycle maximum were allowed, but it was not mandatory, and the adjuvant chemotherapy use were up to the discretion of treating doctors. Complete surgical resection of primary NSCLC with negative margin was essential, and recovery from resection surgery had to be complete. Treatment to start no earlier than 4 weeks following surgery. An MRI or CT scan of the brain had to be done prior to surgery. WHO performance standard is 0 to 1. The exclusion criteria were prior treatment with pre or post-operative radiotherapy, pre-operative chemotherapy, EGFR TKIs, or CYP3A4 inhibitor less than 3 weeks prior. Time between surgery and randomization had to be not more than 10 weeks if no adjuvant chemotherapy was used, or up to 26 weeks if adjuvant chemotherapy was used. Patient who have had only segmentectomy or wedge resection were excluded, and cardiac criteria, including factors that could increase the risk of QTc prolongation or any other arrhythmic event. Just pardon me, please. Any evidence of severe or uncontrolled systemic diseases or any history of ILD or any other malignancy were also excluded. If you look at the baseline characteristic, the demographic and characteristic were generally well balanced between treatment arms, with 2/3 of the patient being female in both the arms. The median age was 64 years. Most of the patients were non-smoker. Asians were predominating by 2/3 to 1/3. WHO performance was 0 in most of the patient, and equal proportion of the patient were divided between stage 1B, 2, and 3A. Almost all of the patient had adenocarcinoma. EGFR mutation randomization was almost similar. Adjuvant chemotherapy, 60% of the patient received adjuvant chemotherapy, while 40% did not receive adjuvant chemotherapy. If you look at the stage 2 and 3A Kaplan-Meier survival curve, the median DFS was 65.8 months with the osimertinib arm compared to only 21.9 months in the placebo arm, with a hazard ratio of 0.23, which is phenomenal. As you can see, the Kaplan-Meier curve started to separate at the beginning itself, and the separation was continued till end of follow-up. If we look in the overall population, the similar benefit is maintained with the hazard ratio of 0.27. Median DFS in overall population being 65.8 months versus 28.1 months in placebo. And here also we see similar diversion of survival curves. 4-year DFS were consistent for the osimertinib arm across disease stages. If we look in the disease stratification stage wise, 1B, 2, and 3A, we see that the 4-year DFS were consistently beneficial in the osimertinib arm, although understandably, the 4-year DFS dropped down from 1B to 3A, that was 80%, 74%, and 65%, and the similar figures were 59%, 42%, only 14%. The hazard ratio was also 0.41, 0.34, and 0.20. So we can say the maximum benefit was observed in patient of stage 3. If we look at the forest plot, we see a DFS benefit with osimertinib was present across all predefined subgroup, irrespective of sex, age, smoking history, race, stage, EGFR mutation, or presence of adjuvant chemotherapy. In all subgroups, benefit of osimertinib was seen. If we look at the overall survival in patient 2 to 3A, we see early snapshot. In the beginning, the curves did not merge much till 1 year, but at the survival curves started to separate after 1 year, we see that the median OS is still not reached in either of the arm. However, the hazard ratio of 0.40 with a wide confidence interval, so maturity is only 5% so far. Patient and investigator remain blinded to treatment in order to facilitate assessment of OS at maturity. So here we can say that there is a trend for overall survival benefit, although it is not established so far. Now we look at the trial of other EGFR TKI in the adjuvant setting. So we see that the DFS benefit has already been proven with other first line and second line EGFR TKI, but no OS benefit was demonstrated. So we had select trial in which the stage 1 to 3 EGFR mutated patient were taken and randomized into erlotinib arm after chemotherapy and radiation therapy. So 2-year DFS for 88% versus 76% in historic control. In Radiant trial, which evaluated the use of erlotinib in the similar population of patient, so clinically meaningful DFS improvement was seen in the EGFR mutated subgroup. This was 46 months versus 28.5 months. The EVAN trial, in which erlotinib was compared with adjuvant chemotherapy, so significant DFS improvement of 42 months versus 21 months was seen. If we look at the adjuvant CT-ONG1104 trial, Jeffery versus adjuvant chemotherapy, the DFS improvement was seen with 28 months versus 18 months. However, there was no significant OS improvement. If we look at the BR.19 trial, in which the similar population of EGFR stage 1B to 3A patients were taken who were not selected for EGFR, Jeffery versus placebo after adjuvant chemotherapy plus minus RT, no DFS or OS benefit were observed, probably because EGFR unselected population was taken. So in ADAURA trial, type of recurrence is also a key consideration, resected NSCLC, as we know that the local versus distant recurrence has an impact on patient outcome post-surgery, and local recurrence is associated with a longer post-recurrence survival compared to distant recurrences, understandably. And CNS recurrence is also one very important aspect which we have to bear in mind whenever we talk about any kind of therapy for CA lung, because CNS recurrence is a very common phenomenon in these cases and often the cause of mortality. Among the patient with EGFR mutated NSCLC who receive EGFR TKI, in those patients also CNS is a common site of distant metastasis. In adjuvant Radiant study, 37% of the patient who had recurrence was actually CNS involvement. Osimertinib has been shown to achieve clinically significant exposure in the brain compared with other EGFR TKI, and it has shown greater penetration of blood-brain barrier. In the advanced NSCLC setting, first-line osimertinib demonstrated superior overall survival and a 52% reduction in the risk of CNS progression compared with erlotinib or geftinib. If we look at the type of disease recurrence, so here we have both the arm osimertinib and placebo arm, and here we say in the osimertinib arm 11% patient had a DFS event while 89% patient did not have any DFS event. Among those 11% patient who had any kind of recurrence, the 38% patient had distant recurrence while only 62% patient had loco-regional recurrence. Majority of the patient had loco-regional recurrence. While if you look at the placebo arm, we see 46% of the patient had some kind of DFS event, which is almost 4 times that of the osimertinib arm. If we bifurcate this 46% into distant versus local, we see majority of the recurrences were CNS recurrence, That is 61%, sorry, not CNS, the distant recurrence compared to 39% in loco-regional recurrence. So we can conclude that osimertinib, first thing, it is preventing the recurrences per se, but also within recurrences, it is preventing distant metastasis even more. So even if patients who relapse are mostly loco-regional, which can be treated easily. And if we look at the site of disease recurrence in the overall per population, fewer patients treated with osimertinib had disease recurrence, that is 93 patients out of 339 compared with placebo. Lung was the most common site of disease, followed by lymph node and then CNS, bone, pleura, and liver, and then other rare metastasis. If we see, incidence of recurrence in all the organs was much less in the osimertinib arm compared to placebo. Particularly speaking, the incidence was half in CNS site. The most common first site of recurrence were lung, lymph node, and CNS in the osimertinib group, and similar picture in the placebo group. If we look at the stage 2 to 3A disease only, in which CNS DFS was calculated, so 63 patients in osimertinib arm in total, out of which 22 in osimertinib arm and 41 patients in the placebo arm had CNS DFS event. 3 patients per on treatment at the time of CNS recurrence with osimertinib arm versus 29 patients with the placebo arm. We look at the CNS DFS to clear separation of curves starting from the beginning of follow-up. So median CNS DFS was not reached in either arm, while the hazard ratio was 0.24 with 13% maturity of data. If we look at the safety summary, 66% of the patient completed 3 years of osimertinib therapy, while only 41% patient completed placebo therapy. Median total duration of exposure was 35.8 months, which is as good as the planned 36 months, and 25.1 months in the placebo group. 98% patient in both the arms had any kind of adverse event which is noticeable. But if you look at any adverse event which is grade 3 or 4 in the osimertinib arm, 23% patient, which is acceptable compared to 14% in the placebo arm. Any serious side effect leading to discontinuation was 13% in the osimertinib arm, and dose interruption was needed in 27% of the patient. If no patient had death because of the adverse event. If we look at the all causality adverse event in more than 10% of the patient, if we look at the osimertinib, diarrhea was most common, although it was mostly grade 1 or 2 and very few patients. Only 3 patients had grade 3 or 4 diarrhea, paronychia, dry skin, pruritus with other common symptoms. In interstitial lung disease was reported in 3% patient in the osimertinib arm, and all were grade 1 or 2. QTC prolongation was reported in 9% of the patient in the osimertinib arm and 2% patient in the placebo arm. So overall, it was a safe drug. Then we have a real world data where post-operative chemotherapy used and outcomes from ADAURA was reported. Adjuvant chemotherapy use overall, 60% of the patient previously discussed. 60% of the patient received adjuvant chemotherapy for a median duration of 4 cycles consistent across treatment arms. The majority of the patient received platinum-based chemotherapy, mostly with the stage 2 to 3A disease and fewer with the stage 1B disease. Adjuvant chemotherapy use were more frequent in patient age less than 70 years and in patient enrolled in Asia, and it was not influenced by WHO performance status. If we look at the number of patients, so they got almost equal in all the stages, and 26% patient in stage 1B, 71% patient in stage 2, and 80% patient in the stage 3A received adjuvant chemotherapy. Understandably, as the stage was higher, the physicians were more inclined to give adjuvant chemotherapy. If we look at DFS in patient with or without adjuvant chemotherapy, so patient who received adjuvant chemotherapy, the 2-year OS DFS was 89% in the osimertinib arm versus 49% in the placebo arm. In patient who did not receive any adjuvant chemotherapy, the similar curves were, its figures were 89% versus 58%. So we can safely say that osimertinib was effective irrespective of whether adjuvant chemotherapy was given or not. The median DFS in patient who had received adjuvant chemotherapy did not reach in osimertinib arm. It was 22.1 month with a hazard ratio of 0.16. While in patient who did not receive any adjuvant chemotherapy, the hazard ratio was 0.23. If we look at by the disease stage, the benefit was present across all stages with or without adjuvant chemotherapy. Osimertinib was better. If we look in stage 1B patient, DFS in patient with and without adjuvant chemotherapy, similar picture is there. The osimertinib was effective. If we look at stage 2, the curves were even widened with the hazard ratio of 0.15 and 0.20. If we look at stage 3, curves are even largely wider. So overall, we can say we look at three curves consecutively. We see from stage 1 to stage 2 to stage 3. There is even further gap in the survival curves. And the benefit of osimertinib was there whether patient had received adjuvant chemotherapy or not. And the quantum of benefit was more in stage 3 compared to stage 2 and stage 1. Coming to the patient-reported outcomes from ADAURA trial. So ADAURA had used health-related quality of life method in which SF36 form was used, which has two components. One is physical component summary called as PCS and another is mental component summary MCS, in which various components were taken like physical functioning, physical role, bodily pain, general health, vitality, social functioning, emotional role, and mental health. So it was a generic health survey. It was not cancer specific and it assessed health related quality of life in the past 4 weeks in patients who are cancer free after surgery. Two summary scores, MCS and MCS, were taken across 8 health domains. So health related quality of life data collection period was at the time of randomization at week 12, at week 24, and then every 24 weeks until disease recurrence, treatment completion or treatment discontinuation. So if we see compliance with the SF36 health survey, compliance rate with SF36 health survey were high in both the osimertinib and placebo arm. More than 85% in both the arms were compliant with health related quality of survey. If we look at time to deterioration of physical and mental component summary, we see both the curves are merging. So we can see that during the disease-free period, the majority of the patient did not experience a clinically meaningful deterioration in PCS or MCS. And for patients who had deterioration, there were no difference in TTD of PCS or MCS. So as to say that the osimertinib or placebo use did not lead to deterioration in quality of life in most of the patient. And even in those patients where it did, the quantum of deterioration in osimertinib arm was similar to that of placebo. So osimertinib was compatible with a good quality of life. To summarize, in ADAURA trial summary, updated DFS analysis of osimertinib versus placebo, patients have been followed for a further 2 years and all had the opportunity to complete 3 years of planned study treatment. Overall, there was a 77% reduction in the risk of disease recurrence or death with adjuvant osimertinib versus placebo, with a DFS hazard ratio of 0.23 in the stage 2 and 3A population. Median DFS was 65.8 months in the osimertinib arm and 21.9 months in the placebo arm. There was also a 73% reduction in the risk of disease recurrence or death with adjuvant osimertinib versus placebo, with a DFS hazard ratio of 0.27 and in overall population. An improvement in DFS was seen regardless of whether patient received prior adjuvant chemotherapy or not. DFS benefit across disease stages was consistent following restaging based on HACC UICC 8th edition manual. Osimertinib demonstrated a clinically meaningful improvement in CNS DFS across stage 2 to 3A, hazard ratio being 0.24. The safety profile was consistent with the established safety profile of osimertinib and no new safety concerns were reported. With an extended treatment duration, median total duration of exposure to osimertinib was 35.8 months, which is almost equal to the planned duration of therapy. So all these updated data, they reinforce adjuvant osimertinib as a standard of care for patients with EGFR mutated stage 1B to 3A NSCLC after complete tumor resection with or without adjuvant chemotherapy. Thanks a lot. So now is the time to take any question. If any, I will be happy to answer. So since there are no further questions, so I would like to invite Dr. Anshul Gupta for the next talk. Can somebody confirm whether Dr. Anshul is now available?
Sir, he has not log in right now.
I think we'll just wait for 2-3 minutes.
Sure, sir, sure.
Hello everyone. So I just had a word with Dr. Anshul Gupta due to some personal emergency. He's not been able to attend the session today. So I think now I would conclude the session then.
Sure,
Over
sir.
to our managers.
Uh, so if you want, like, you can present his deck. I have his slides, if it is
Okay,
possible.
sure, sure. Sure, sure. If you can share on my behalf, so I'll
Sure,
be
sir.
reading out the slides.
Technical team, can you present Dr. Anshul Gupta's slide?
Yes, sir. Wait.
So you can continue.
Hello everyone. So in view of Dr. Anshul's unavailability, hello everyone. So in view of Dr. Anshul's unavailability, so I will be taking his lecture. So the topic for that is decoding treatment option for EGFR mutated NSCLC. Next slide, please. So if we look at the worldwide data of all cancer, we knew that according to Globocan data 2022, both sexes, we see that the most common cancer is female breast cancer, followed by lung cancer, which is an important incidence. And if we look at the number of deaths, so lung cancer has 18% share in the number of deaths, which is highest among cancers. Next slide, please. So in both sexes combined, lung cancer is the second most common diagnosed malignancy, which is 11.4% of the total cases, and it is a leading cause of cancer death, causing 18% of the total cancer death. This is a global data that we are talking about. Next slide, please. There are various parameters which determine the choice of first-line treatment in advanced EGFR mutated NSCLC. They include progression-free survival, overall response rate, presence of brain metastasis, safety and toxicity, quality of life, and patient receiving subsequent therapy upon progression. Next slide, please. And we know that we had various generation of TKIs, first generation TKI, second generation, and third generation TKI, in which the osimertinib has provided unprecedented improvement in PFS in the FLORA trial. So first we had geftinib, in which the IPAS trial was there. So median PFS was 9.5 months. In erlotinib, the optimal trial, the median PFS was reached to 13.1 months. In the Lux Lung 7 trial of afatinib, the median PFS was 11 months. And in the Archer trial of 1050 of dacomitinib, median PFS reached up to 14.7 months. It is only with the FLORA trial of osimertinib where we saw the median PFS reaching 18.9 months, which was very good. Next slide, please. If we look at the efficacy progression-free survival, the Lux Lung 7 trial of afatinib versus geftinib, the stable brain mets were included. 16% patients had stable brain mets. While in Archer 1050 trial of dacomitinib, the brain mets were excluded. And in FLORA trial, stable brain mets were included. That was 19%. Here we see, when we look at the curves started separating in the Lux Lung 7 trial after a gap of 12 months. While they started separating after 6 months in the Archer trial, while in FLORA trial, there was immediate separation of curves. So the benefit of osimertinib was started in almost all of the patient. And we have to take this data with a pinch of caution because the cross trial comparison without head to head comparative studies can be misleading. Next slide, please. Early separation of PFS curve is shown by osimertinib only, as already explained. Next slide. If we look at the overall response rate was 70% in the afatinib, and median DOR was 10.1 months. So values were lower in the geftinib, which was the comparator arm, and disease control rate for 91%, with duration of disease control being 12.7 months. If we look at the Archer 1050 dacomitinib trial, the ORR was 75%, which is somewhat okay, and median duration of response was 14.8 months, which was significantly higher than geftinib. However, we look at FLORA trial, the ORR was 80%, which was higher than both of them. And the median duration of response was 17.2 months, which was also higher than its first generation, second generation TKIs. Next slide, please. So Ortiz-Multinib has shown the highest ORR and median DOR compared to afatinib and dacomitinib. Next slide, please. If we look at the overall survival of FLORA trial, the final analysis, we see that the curve started separating very early and the median OS was 38.6 months in the osimertinib arm compared with 31.8 months in the comparator arm with a hazard ratio of 0.79 with a confidence interval of 0.64 to 0.997, and curves started separating beautifully from the beginning itself. If we look at the three-year OS, it was 54% versus 44%. So 10% patient lived more at the end of 3 years. Median OS was more than 3 years, and the osimertinib patient were more likely to be alive at second and third year landmarks. First time an EGFR TKI had translated PFS to a significant OS benefit. Next slide, please. If we look at the Lung 7 and Archer trial, Lux Lung 7 and Archer 1050 trial. So if we look at PFS benefit was seen in both the trials, but if we look at the OS curve, so the curves seem to merge and the afatinib did not show significant OS benefit. OS was 27.9 months versus 24.5 months with a hazard ratio of 0.86, which was not statistically significant. So afatinib failed to improve OS versus geftinib. If we look at the Archer trial, the curve so median OS was 34.1 months in dacomitinib arm and 27 months in the geftinib arm with a hazard ratio of 0.748. However, if we look at the OS 42 data, so it was 41 months versus 33.1 months, and curve started separating. In Archer 10, a hierarchical gatekeeping procedure was used for hypothesis testing. So first PFS was tested. If it was significant, then only ORR, and if ORR was significant, then only OS was measured. ORR was not statistically significant, and hence formal statistical hypothesis testing for OS was not conducted. So hence we cannot say for sure that dacomitinib improved overall survival. Next slide, please. So we have a Canadian consensus guideline in which a new systemic treatment algorithm for advanced EGFR mutated NSCLC was proposed in 2022. The phase 3 Archer 1050 trial excluded patients with brain metastasis, although it reported a numeric improvement in OS of 34 months for dacomitinib compared with 26.8 months for geftinib. Hazard ratio was 0.76. The trial had a hierarchical stratified statistical design, hence it did not meet significance in ORR. A p-value could not be given to OS. Next slide, please. So if we look at the number of patients who were receiving osimertinib at the end of 3 years, the figure was 28%, which was quite high. If we look at landmark time, at 12 months, 70% patients were on osimertinib compared to 47% in comparator EGFR TKI. The figure dropped to 42% versus 16%, and at the end of 3 years, 28% versus 9%. 22% versus 5% of patients are still on treatment at data cutoff time. Next slide, please. Osimertinib also demonstrated a superior systemic benefit regardless of CNS disease status at study entry versus EGFR TKI comparator. If we take the patient who had known or treated CNS metastasis, the hazard ratio was 0.47 for median PFS, and the median PFS was 15.2 months in the osimertinib arm versus 9.6 months in the standard of care arm. In patients who did not have any CNS metastasis, the similar benefit was there with the median OS for 19.1 months versus 10.9 months in the standard of care arm with the hazard ratio of 0.46. So osimertinib was effective in patients even who had CNS metastasis. CNS progression events occurred in 6% of the patient in the osimertinib arm versus 15% of the patient who were receiving prior standard of care EGFR TKI. Next slide, please. Intracranial PFS, if we look, then the median CNS PFS was not reached in the osimertinib arm versus for 14 months in the standard of care arm with a hazard ratio of 0.48, which is statistically significant after a median follow-up of 12.4 months in the osimertinib arm and 7 months in the standard of care arm. If we look at the curves, so they are separating nicely. So there is no confusion that CNS PFS was statistically significant with osimertinib compared to comparator arm. Next slide, please. Significant CNS response to first-line osimertinib in patient who had CNS metastasis in EGFR mutated advanced NSCLC and CNS metastasis if we see. In afatinib Lux Lung trial if we see, so baseline asymptomatic brain metastasis patient were allowed and median CNS PFS was 8.2 months. In the Lux Lung 7 trial also 7.2 months. In dacometinib arm, because brain metastases were excluded, so CNS PFS we cannot measure. While in osimertinib arm, it was 15.2 months. There were almost doubling of median CNS PFS compared to afatinib in osimertinib arm. And baseline asymptomatic CNS metastasis, the median CNS PFS was not reached versus 13.9 months in the geftinib or erlotinib arm. Next slide, please. If we look at the safety, adverse event of grade 3, 4, or 5, the most common, so if we see with the dacometinib, dermatitis was a big problem, followed by diarrhea, maculopapular rash, and pustular rash. In the FLORA trial, the diarrhea was very rare problem, 2.2% only, and fatigue was also 1.4%. So if you see that the grade 3, 4 adverse event with dacometinib was reported in 63% of the patient. Grade 3 or more adverse event with afatinib was in 31% of the patient, while in Lux Lung 7 trial, while grade 3 adverse event in osimertinib arm was only 18% in the FLORA trial. So comparatively speaking, dacometinib and afatinib compared to that, osimertinib was rather safe drug. Next slide, please. If we look at the grade 3 and 4 second and third generation TKI toxicity, so with afatinib arm, 9% of the patient had grade 3 or 4 skin toxicity. Diarrhea was seen in 13% of the patient. In Archer 1040 trial, 14% and 8% diarrhea, while FLORA trial, less than 1% patient had more than grade 3, 4 skin toxicity or diarrhea, or only 2%. So it was comparatively better tolerated drug. Next slide, please. If we look at the dose reductions, so second generation EGFR TKI, afatinib and dacometinib have been shown to frequently cause adverse events that require a dose reduction. In Lux Lung 7 trial, adverse event leading to dose reduction were more frequent in patients receiving afatinib. It was huge, 42% patients, so almost half of the patient required dose interruption or dose reduction. If you look in Archer 1040 trial, there were more dose reduction in patient dacometinib group compared with the geftinib group. It was 67.4%. So dacometinib in terms of adverse event was even worse, with almost 2/3 of the patient requiring dose reduction. While in FLORA trial, the frequency of dose reduction was similar between osimertinib and standard of care EGFR TKI, which was very low, only 5% patients. So osimertinib is a very well tolerated drug, and so is our experience as clinician as well. Next slide, please. If we look at quality of life in Archer 1040 trial, global quality of life was maintained in the dacometinib group, and it was significantly improved in the geftinib group. While we look in the FLORA trial, the global quality of life was improved from baseline in both osimertinib and EGFR TKI comparator group, with no clinically relevant differences between groups. Next slide, please. 1/3 of all EGFR mutated patients treated with first or second generation EGFR TKI are able to receive second line osimertinib. How is that works? Because if we take 10 patients who are EGFR mutation positive who were started on geftinib or erlotinib or afatinib, non-osimertinib drugs, out of them only 1/3 of only 75% patient will receive any kind of second line therapy, because up to 25% of the patient will die during first line therapy or will receive only palliative care upon progression. Out of these patients, 70 to 76% patient will receive a valid T790M test result, and 2 patients out of these will not be eligible for testing because of various limitations like tissue biopsy, insufficient tissue from biopsy, or invalid test result. Out of remaining 6 patients, 50% of those with the valid test result are actually T790M positive, while 3 patients will not be T790M positive, they will be negative. Hence, out of 10 patients who started with EGFR mutation positive patient who started with geftinib erlotinib, only 3 patients will be eligible for second line osimertinib. And 7 out of 10 patients who start on first or second generation EGFR TKI will not be able to receive osimertinib in second line because it is not possible to predict like who will develop T790M resistance. Next slide, please. Access to second line therapy, if you see that we have various trials with us like IPASS, IFUM, NEJ002, WJTOG, YourTech, Optimal, Ensure, CTONG, and LuxLung 367 trials, in which we see subsequent therapy only it is ranging from 60 to 80% of the patient, and approximately 1/3 of the patient will not have access to any second line treatment. In FLORA trial itself, in standard of care TKI arm, the subsequent treatment was received only by 61% of the patients. Next slide, please. If we look at the real world evidence of T790M after afatinib in a Japanese study, 43% patient acquired T790M after first line therapy. In a Taiwanese study, 48% of 42 patients who were rebiopsied after afatinib failure had acquired T790M mutation. In another Taiwanese study of 28 patients who were previously treated with afatinib, T790M mutation was identified in 32% of the patients. Next slide, please. So, less than 50% patient put on afatinib actually acquired T790M mutation, hence losing on the opportunity to receive osimertinib benefit. Next slide. If we look at sequencing of EGFR TKI, so starting with prior generation EGFR TKI and then treating those that develop EGFR T790M mutation with osimertinib is not an optimal clinical care because we are not smart enough yet to figure out who will get EGFR T790M mutation, and not everyone will be well enough to receive additional treatment. 30% of the patient don't receive any subsequent therapy due to various reasons as outlined previously. Tissue liquid biopsies are not always successful. And osimertinib associated with a significant survival benefit as first line therapy. Next slide, please. Uncontrollable factor in sequencing are toxicity to drugs, occurrence of T790M mutation, sites of progression, concurrent morbidity, and patient choice. Next slide. Now we have some real world studies with first line osimertinib as we'll be presenting now. Next slide, please. So first we have FLOWER study, which is first line osimertinib in real world and inter-regional perspective study. So all patients were white with a median age of 68 years. It was conducted in Italy across 9 centers in 126 patients, in which 120 patients had adenocarcinoma. So PS was 2 or more than 2 in 12.7% of the patient. It first line metastatic or advanced EGFR mutated NSCLC patient were taken. Brain mets at the baseline were there in 30% of the patient, which was a bit higher than FLORA trial. Comorbidity index were more than 6 in 93.7% of the patient. If we look at baseline EGFR mutation status, the exon 19 deletion was there in 50% of the patient, and exon 20 L858R mutation were present in 43.7% of the patient. 73% patient achieved a PR, while 23% patient achieved stable disease. Progression was there in 4% of the patient. Median PFS for 19 months. Median PFS in patient with or without brain metastasis for 13.3 months, and in median PFS in patient with or and without symptom and diagnosis for 15.5 months. So we can see that the data median PFS were almost equal to what was seen in the FLORA trial. Next slide, please. So to conclude, in patient without recurrent disease, median time from biopsy to pathological report was 7 days. From pathological report to EGFR mutation status was 8 days. And EGFR mutation status report to osimertinib start was 17 days. And patient who were experiencing progressive disease, 47.7% patient underwent rebiopsy at progression, and tissue rebiopsy was done in 1/3 of the patient, and rest of the patient underwent liquid biopsy. Molecular analysis were performed in 13 samples, and which druggable resistance mechanism like MET amplification was identified in fewer patients. The most common adverse event was diarrhea, which was seen in 39% of the patient, skin rash in 33%, paronychia in 26% of the patient. However, almost all of them was grade 1 or 2, and no grade 3, 4 toxicity was seen. No differences rate of BTE was reported according to age, performance test, comorbidity, and tumor load. No difference in survival outcome was observed according to age, comorbidity, and type of EGFR mutation. Most common adverse event was venous thromboembolism, 7.9%, which was a rare finding because which was not previously mentioned in the FLORA trial. Osimertinib confirmed effectiveness and safety in the real world, although thromboembolism was more frequent than previously reported. Next slide, please. Next, we have OSI FACT study, which is osimertinib as first-line treatment for advanced EGFR mutated positive NSCLC in real-world setting. This study was conducted in Japan with 538 patients, which was a retrospective multi-center cohort study. Median age was 71 years. Almost all the patients were adenocarcinoma. 16% patients were PS2 or more. Brain metastasis were also 30%. Here we had also classified PDL1 TPS status, in which 12% patient had more than 50%, 31.6% patient had 1 to 49%, and 30% patient had less than 1%. And here outcome, if we look, ORR was 76.1% and disease control rate was 94.1%, which is excellent. It is as per FLORA trial. Median PFS was 20.5 months and median TTF was 19.1 months, which is similar to what was observed in FLORA trial. Next slide, please. Pneumonitis was a common problem here, and it was seen that 12.8% of the patient developed pneumonitis, out of which grade 3 or 4 was in 4% of the patient. And median time from start of treatment to the onset of AE was 56 days. Pneumonitis was there in 4.5% patient, grade 3. Fatal pneumonitis occurred in 4% of the patient. Pneumonitis of all grades were higher as compared to the FLORA trial. So PFS after first-line osimertinib treatment in real-world practice was favorable. The discontinuation rate due to adverse event, specifically pneumonitis, requires further investigation. So we can see in the real world, we saw that pneumonitis and venous thromboembolism, these were the two complications being seen, which was not observed in FLORA trial. Next slide, please. Next, we have a Mykonos study, similar setting like FLORA trial. The study was conducted in USA, Japan, Germany, and China. It was a global observational cohort studies. Median age was 70 years and 14.4% patient had PS more than 2. Brain mets were there in 33.6% patients. So if you see the FLORA trial, 18% patient had brain metastasis, while in the real world studies, approximately 1/3 of the patient, 30% patient had brain metastasis. If we look at the EGFR mutation profile, so it was equally divided between exon 19 and exon 21 mutation. At an interim analysis, 58% patient remained on first-line osimertinib therapy or were lost to follow-up. 18.8% patient received second-line treatment, and 18.4% patient died while on first-line treatment. 4.7% patient discontinued first-line treatment. Here, the primary outcome that was taken was real-world time to next treatment of death and time to treatment discontinuation. So it was 17.9 months, and RWTTD was 17.2 months, which is quite good. Interim reports support the effectiveness of osimertinib in this real-world population. Longer-term outcomes will be evaluated in final analysis, which is still awaited. Next slide, please. So what are the guidelines saying now? Next slide. So if we look at the NCCN guidelines, so previously, so EGFR exon 19 deletion or L858R mutation, if we see, if the mutation is detected prior to beginning of first-line systemic therapy, then preferred treatment, category 1 indication is osimertinib. Sometimes it may so happen because we know that the EGFR mutation, biopsy, mutation testing, all these things take time. Patient may be symptomatic and we do start systemic therapy before the EGFR report becomes available. In such patients, the preferred option is to interrupt the systemic therapy and to begin osimertinib. Other acceptable approaches are to complete planned systemic therapy, including maintenance therapy. Next slide, please. So, if we have ESCO living guidelines, patient with stage 4 NSCLC who have non-squamous cell carcinoma and squamous cell carcinoma who have sensitizing EGFR mutation, osimertinib monotherapy is a very strong recommendation. The moderate recommendation are for second line and first line EGFR TKI like gefitinib, dacomitinib, erlotinib, monotherapy, along with combination with bevacizumab, ramucirumab, or doublet chemotherapy. Weak recommendation are monotherapy with osimertinib, gefitinib, or erlotinib. Next slide, please. To summarize, Osimertinib is the only EGFR TKI which has demonstrated a clinically and statistically significant improvement in overall survival. The median OS benefit of greater than 3 years sets a new benchmark for osimertinib, and it provides a window of opportunity for the management of patients with stage 4 NSCLC with sensitizing mutation, reaffirming its importance as the first-line therapy. FLORA is the first time an EGFR TKI has translated PFS into an OS benefit. Nearly 30% of the patients remain on osimertinib at 3 years, and osimertinib is the only drug which can be given in patients with brain metastasis and T790M mutations. Osimertinib is the safest and least toxic drug among all available options. Sequencing cannot be considered the best strategy as almost 70% patients are not eligible to receive osimertinib in second line. All these data confirm osimertinib as first-line standard of care in metastatic EGFR mutated NSCLC. Next slide. Thanks a lot. Any questions are welcome.
Thank you,
Over to
Dr. Kapil sir.
organizers.
Yeah, thank you, Dr. Kapil sir, for enlightening us for the sessions and all the esteemed faculty for giving some informative information. And thank you all the pharma for making this webinar a successful one. This is Ankit Khare and Devashish from Healthy Blossom signing off, sir. Good night.
Okay.